cope with it. So don't mention us normal, because we are just people, person, individuals, etc. So that's maybe one thing I would like to say. If it's going to be a discussion, I don't know, but back to you.
No, I think that's an important comment, and this makes all the difference between, you know, diabetes as a chronic condition and what we are all aiming for, which is a cure for the disease. So perhaps can we ask some members of the panel doing diabetes research, whether, you know, in academia or in industry, you know, how they see, you know, what we have to do regarding diabetes as a chronic condition versus, you know, to go for a cure, which is, I think, what especially GDRF is fighting for.
Okay, I can say a few words. I really think that we need it all, and even I see patients. And when I look back, I think all the real, discoveries came from the patient by themselves, because there was something said that didn't fit into the picture. And it doesn't really stop with LADA. We know that there are still a lot of these patients out there that really would not fit into this. Whether this then would lead into, let's say, a novel treatment, we doesn't know. But someone's talking about time. I don't think there's been a better time to be in science than now, because for the simple reason that the only limitation is our own imagination. The tools and the technology and all that is there. Maybe not all the money to do all that thing we can do. But I think that's really, now it's a question of really trying to join, combine resources to solve the problem, find a cure for diabetes.
Thank you, Magda, for inviting me here. I would like to raise another category which was not mentioned in this field. It was gestational diabetes, because I'm an obstetrician. So these are special kind of person, healthy, young. As your relative said, I want to do my children. No, it is very important to know before making your children to know your risk of diabetes, especially in your family. And I rise up that it is a sad story that you, with your mother and child and father and family history, you had to wait till 40 to assess your risk. I don't know if you have children or not, but the risk assessment should have been done at the childbearing age of any woman. And after research on gestational diabetes, I would be sure that the man would like also to carry some pregnancies in their 20s to be sure that assess their risk of diabetes. So gestational diabetes, young person, healthy, and they should be investigated, and they should be evaluated from their diabetes risk. It's like a test, it's a pregnancy test. So this is a special category, should be assessed more, at least in the future. And that's why I was very sad when I heard the NIH panel conclusions last year in June. They say they don't want to do the one-step test. They want to stay on the two steps for gestational diabetes, just because the diagnosis is 11% from the pregnancies in the 2 steps and 17 in a one-step testing. So I will stop here because these are special discussion, but in a world with increasing diabetes and diabetes awareness, I think we should focus also on this group, also should be put in the list of the industry.
Yes, so, okay, I mean, the atmosphere is very gloom. You know, we should be very optimistic. The NIH, well, we can be very optimistic. We just got news 2 days ago that we are through to phase 2 on a big European project on gestational diabetes, where we want to evaluate in the European context, I don't know who said it, America, South America, Africa is very different from Europe. And within Europe, there's even different ethnicities and what have you. But so we will have a a project with 6 or 7 centers with the support of EPCOG, the European obstetricians, blah, blah, blah. Bon. We will have a project where we will scientifically be able to see whether 1-step or 2-step makes sense. So I wouldn't be too gloomy. I mean, we need to have the scientific data to see what is the best way to test for gestational diabetes. But there's no doubt that women with gestational diabetes have the highest risk for type 2 diabetes of all people. So fully agree, but Europe will support, hopefully if we get the money, they will support a project. Can I just come back to this concept of cure? We have to be very careful because, I mean, as there is no such thing as normality, I'm not normal, you know, nobody is normal, I think. What is normal? But people we transplant with a pancreas sometimes think, I'm cured. It's a different way of treating your diabetes. So we have this concept in science that advancing step by step and that an incremental step is not a good thing. When a reviewer writes that on your grant, you will not be funded. But perhaps incremental steps are not so crazy in clinic. And again, as industry says, we will find new tools and they will appear to be incremental steps, but they will impact on the life of our patients dramatically. It's not because you are with Sanofi, but the first basal insulin analog, Lantus, has dramatically changed the life of our patients. And so every step we can make is an important step. And so don't give up hope. I don't know who said it. Cure will not be for me. There will be very important steps we will be able to do that will impact dramatically on your life. And cure, we will never be able, I think, to change your genes, but we will be able to, you know, treat it differently. He wants to mutate you. Do you want to? Okay. But so I think we will get there. Even for you, we will get there. We will make our steps in the right direction. But is it a cure? Will it ever be a cure? Even if we can reinstall tolerance of your immune system to a beta cell, or even if we can make, with Decios help, your beta cell stronger, you will still have, you know, the background for your disease. But that's okay if we can take away all the rest. So.
Just a quick response. I think Lantus was a little bit more than incremental. And I still think it's, I mean, the goal can be to move from dark to white, even if we never would achieve it. But I think it's fair to have that as the final goal, to cure.
Just to make a small comment. So we are discussing about incremental steps and steps that make the treatment easier. But perhaps we should also keep in mind the long-term objective, which is to actually cure or prevent disease. And at this stage, it's good to keep in mind, and all the Buddhists say that an ignorant, aware of its own or his or her own ignorance, is wise at least so far. And I think one of the big problems that we have both in type 1 and in type 2 is that we do not understand the pathogenesis of these two syndromes. So when we are discussing about IMI and putting emphasis on translational medicine and new therapies, translational medicine of what? So as soon as we do not understand what's the basic pathogenesis of these two syndromes, it's very difficult to translate. So the point that I would like to make is that these initiatives and these attempts of translation needs to go hand in hand with fundamental research to try to understand what is going wrong with the pancreatic beta cells and the other components of these syndromes.
Philip, do you want to comment?
Well, it's
right up the alley of the IMI2 program for all of the different things we've been discussing so far, as you will learn this afternoon. This is very much in line with what thoughts we have in industry.
May I ask you to state your name and affiliation first to all those asking questions? Thank you.
What do you think, what role could genetics play in diagnosis or possible treatment?
We know from some, I mean, from the what we call the monogenic forms, that where the gene effect is so strong that you get the disease by birth or early on in life. And for long we thought that there's nothing in between these and type 2 and type 1. But we're just starting to be able to dissect this. So I think in terms of describing the heterogeneity of the disease, it will help. But it's clear when it comes to, let's say, to treatment. I mean, I think what pharma and also researchers like to do today is to switch from looking for genes that increase risk of the disease towards those who protect from disease. So we are more focusing now on those who, having all risk factors, but escape the disease. And published a few months ago, one of those projects where clearly, I mean, it looks like a gene encoding for a zinc transporter seems to protect from diabetes. We don't know, but maybe one day that actually can be taken to a drug. And the good thing with doing this is that if Mother Nature can do it without, you can think that the drug development will be faster and with less side effects. But it still has to be proven. But PCSK9, as you showed, is also one of those, is actually really the ultimate story that generated this interest.
Well, if we could pick up on that theme, I mean, so both Philip and Leif, you're suggesting that possible solutions may exist literally on the stage here. In other words, our patients could be highly instructive, and yet we're not leveraging that asset very effectively. So thoughts, Philip and Leif, how we could leverage that asset, really better understanding the patient more effectively? What it is they can contribute? How could we empower them? How could we partner more effectively?
I mean, Leif's already working on that, having this prospective cohort of all newly diagnosed people in his local region. And this obviously we can hopefully inspire, I would say, a dissemination of that thought throughout not just Europe, but other parts of the world, because I'm absolutely convinced that diabetes comes in so many flavors depending on what genes you have, depending on what environment you're exposed to. So we need this more prospective outlook, and this is exactly the thoughts that lies behind several of the initiatives we want to launch with IMI2. Really trying to establish these networks, and forward-looking networks, so we capture all the variants as a source for inspiration, because I think we have to admit, perhaps it's a little embarrassing, but we have to admit that we quite frankly know very little about the wider variation of genetics, environment, and disease etiology. And we have these unique stories of single gene mutations, but when we're talking about complexity of putting many gene variants into one individual, then I think we come short.
I think, Pim, you please identify yourself. Thank you.
Okay, well, thank you. I'm Pim de Boer from the Netherlands. I have two questions, and the first one is a follow-up on the last question. I'm myself involved in two different IMI projects, in which patient involvement is something that we developed from the very beginning on. And the question is, of course, how will patients or patient representatives be involved from the onset of research through the whole process of research, doing the research, and perhaps that will be addressed later on this day. But this is a question that can be posed both to the patient representatives as well as to the researchers and the clinicians. So that's the first question. You may answer it, or it can be answered later on. And the second question is also related to that. Well, thinking about personalized medicine as a concept for individual patients, I quite often hear something about genetics, but personalized medicine is part of personalized health. And although personalized health as such is perhaps not the very scope of IMI, but it is inherently combined and intertwined with each other. So looking at the data you can get from patients and healthy volunteers, what do you do with the non-physically measurable parameters, like the patient-reported outcomes? Are they being taken into account? You can learn quite a lot from what patients tell you beyond those things that you can measure.
I can try to give my view. I think it's a misconception that it's either genes or environment and lifestyle. Take the example of the lactose intolerance. That gene started to mutate up in Africa and Asia when people started to domestic cattle because it was a benefit of being as an adult to utilize the energy from milk. So that's still how genes interact with the environment, always interact. So I fully agree, it's very important. Some of the problems is that we don't really know those triggers, but we really need them. The good thing with genetics in diabetes, it usually affects families. And really the family is probably the biggest and greatest resource for all these studies.
Yeah, I mean, I do personalized medicine like all clinicians every day because every patient is different. And so you need to approach them differently. And having patients involved in initiatives very early on is, I think, crucial for industry. I've lived the story of Exubera, the inhaled insulin. I was in the International Advisory Board, advising Heugst in these days and Pfizer. And we thought we listened to the patients because they said, you know, we don't like to inject insulin. And then we came up, or they came up with this inhaled insulin with such a big device, like the microphone, and then that was one thing. But then also when the patients were really presented with the inhaled insulin, they said, oh no, we still need to measure our glucose. Oh no, we can still have hypos. So what they were saying is not we don't like to inject insulin, but we don't like to inject insulin. And so if we, the advisors and the companies, would have listened better to the patients and had them involved from the beginning, millions would have been saved. So I think it's crucial to have patients involved, but not as an excuse. Because now patients are everywhere. PROs, patient-related outcomes, are measured in every clinical study we do nowadays. What do we do with them? Nothing. So I think patients need to be involved from the beginning, and they have a voice. But we should listen to them, and really listen to them. And sometimes it's very confronting as a clinician when you come with a new drug to a patient, you say, I have something for you, and you'll be happy, and then, or a new meter. And then they look at it and they say, no, this is wrong. If we'd known in the beginning, we would have done it differently. So indeed, an advice to us, but also to industry, have patients on board from the beginning and listen to them.
Thank you. Please. Well, personally, I've volunteered for a lot of voluntary participation in trials, testing new kit. The latest one have been with the sensor, and I've been to a few dialogues with doctors too about it. And I actually feel that we do get whatever she just told covered. We do talk to doctors about how this affects us and how it actually works in us and if it's good or not. Personally, the sensors are, for me, one of the biggest steps since the insulin pump came out. So I've been very glad. So, and I also want to say, now that I have the opportunity, that all those steps that has been taken since I was born and I was diagnosed with diabetes has really been a huge reason to enjoy for me, that we're getting closer to a cure, that we're not just standing at a still point and there's nothing to do about it. I really enjoy seeing improvements in the different. I really enjoy seeing improvement in, improving in the kid.
Please.
Yes, I have a question. Hildrun Sunset from the European Institute of Women's Health. So I want to go back to our dream scenario of a cure and prevention. And here I have a question to the researchers. Do we know, in terms of prevention, it seems to me it runs in families. So I'm looking at the future generation, because that's in a way women are responsible for, and the colleague there mentioned gestational diabetes. I'd like to understand how much you know about being able to influence already in utero the environment for the fetus, for the child, future child, to go prevention that way through this method, rather than rely, like we have all the preaching about lifestyles, etc., you know, which is very, very important. And I think this is a question that I'd like to target also against the background of the increasing obesity crisis, especially in young women. Thank you.
Leif will probably be able to give some data, because in their network, Hans Hering is doing very nice studies in utero, blah, blah, blah. But you raise a very important point, namely already going for the fetus in utero. The fetus is not a patient. He's a healthy person. And so that's another thing we haven't talked about. In the whole initiative we're talking about here, we should also have regulators on board. We should have EMA, our fantastic European Medicines Agency that does really very good work, scientifically high level. They listen to clinicians, they get advice before they talk to industry. But we should have them on board. Because, I mean, for industry, when they hear going for a fetus, their ears go like, ugh, because it's not a patient. So having them on board, having them in the discussion, if we find from our science arguments to say, well, this is a thing that will not work once you're 15 years of age, but might work when you're a fetus, an immune intervention, a blah, blah. How can we go to EMA, to the regulator? So they need to be in all these initiatives early on, like the patients, so that they can guide us where we want to go.
I think it's a very important question, but we don't really have enough information. The only thing we know that, I mean, good nutrition during pregnancy prevent obesity, but there are a lot of other things that could go on. I mean, to get to a situation like, I mean, to get the benefits of folate supplementation to prevent meningomyelocele, we are far from that. But still, yesterday, I actually have a PhD student who's a physician in Punjab in India, and she has been looking at gestational diabetes over there. I can see that there's I mean, first of all, they have 3 to 4 times higher prevalence of gestational diabetes in India. And clearly, I mean, also amazed to see how much more they had in the rural than in the urban areas. So it's clearly, I mean, a lot of social, I mean, factors influencing it.
Okay, thank you very much. I think that we have to close this first session, knowing that we will come back to many of the questions raised in the second part of this morning session. So thank you to all the speakers, and I suggest that we reconvene at 11:35. Thank you very much.